Welcome. Delighted to see so many of you here for what is a very exciting event. It's our very first SRI inaugural lecture, so extremely excited about that. My name's Toby Seddon. I have the pleasure of starting things off this evening and also the privilege of being the current head of SRI. Inaugural lectures are important things in the life of an academic department. They're an occasion where we celebrate in an unequivocally positive way the achievements of one of our own, and we do this in the company of colleagues, students, friends, family. So they're a very celebratory, positive occasion, really important for the community of an academic department. Now, it's very fitting, in fact, for lots of reasons, that Jenny should be the first person in our new inaugural lecture series, not least because we literally would not be here but for Jenny, because we have been talking for a number of years about we really should have an inaugural lecture series, and it was only through a relatively recent SRI event, talking to Jenny, that she persuaded me, yes, I do need to get it together and we should do this. So it's thanks to Jenny that finally the idea has come to fruition. So very fitting that you should be doing the inaugural for us. So thank you, Jenny. But also quite fitting that it's you as well in lots of other ways, because I think in many ways Jenny and Jenny's work and the way she does her work exemplify what I see as some of the really special things about SRI as a department. So I'm not going to talk about the multidisciplinarity of her work or her commitment to policy engagement, because Alison is going to say some words about that. I'm going to say something a little bit more personal about Jenny as a colleague, as a person. My first contact with Jenny of any description was receiving an email asking me, inviting me to do some teaching on one of our modules. And if memory serves, this email actually came before I joined UCL. So I thought, this is somebody to be reckoned with, somebody who is on top of their game, well organised, and these are, of course, all Jenny hallmarks. And so I was very happy to do this and did the first session. Obviously, when I joined, this was 2020, so this was online. We were in lockdown. The year after, I was able to do it in person, which was great, to be in the room with the students. It was 9 a.m., not so great for a lecture. And although she didn't need to come, Jenny did come for 9 a.m. to make sure everything was all right. And then she also did something very kind, which she said, oh, I thought you might like a coffee. And she brought me a coffee as it was 9 a.m. And I really did need that for a 9 a.m. lecture. And it was a small thing, but it was the kind of kindness that I think exemplifies the sort of colleague Jenny is. And it really stuck with me as just a nice little gesture that not everyone does, but that was actually really good thing on the day for me at 9 a.m. to think, yeah, nice people, nice place, let's do this lecture. And I think our success as a department is, yes, built on having lots of brilliant, clever people as colleagues, and we do have lots of those, but I think our success also hinges on the human factor, the relationships that we have in the department, and the little bits of kindness and collegiality and the relationships that we have with each other. And that's really important. And I think that is where the magic of SRI happens, is in that collegiality and the little acts of kindness, like bringing someone a coffee, that make a difference. And Jenny, I can't think of anyone else who better embodies those sorts of ways of wanting to be a colleague, ways of wanting to be an academic. So it's particularly fitting that you are our first inaugural lecture giver. Now, another thing I know about Jenny, she's quite a modest person. She just gets on with the job. She doesn't like to blow her own trumpet. So I know I will already have embarrassed you. So that's as it should be in an introduction. And I'm now going to hand over to Alison, who I know is going to embarrass you further. So
I'll certainly do my best. Thank you very much, Toby. And it's good evening, everybody. It's really my tremendous pleasure to say a few words more to introduce Jenny or Professor Woodman. I'm Alison Koslowski. I've got lots of hats at UCL. I'm Pro-Provost Equity and Inclusion, so UCL's Senior Academic Champion for all things EDI. I'm Jenny's line manager, which doesn't take up much time. Mainly consists of trying to suggest that Jenny might want to do slightly less at any one given time. And the reason I've got saying a few words now is I'm co-director of the Thomas Coram Research Unit, or TCRU as we're more colloquially known, which is one of Jenny's homes at UCL. So Thomas Coram is well known, I think, in this part of Bloomsbury. Some of you in the room may be familiar with Coram Fields, just across the way from here, which is a lovely little park for families and children. No adults allowed in without children. I just went past the sign on the way in. There's the charity Coram and the founding museum, which was the hospital, just across the park from here. And Thomas Coram was someone who was shocked at the situation of the poorest children in London back in the 1730s. And he set wheels in motion such that the philanthropic work that he started is still going strong some 300 years later. And I like to think that Thomas Coram would be very, very happy to have his name associated with Professor Jenny Woodman. At the Thomas Coram Research Unit, we aim to be leaders of world-class research which provides evidence to improve the lives of children, young people and families in the UK and globally. We have a long-standing commitment to engaging with policy and practice, knowledge exchange and outreach, and we're proudly multidisciplinary and methodologically diverse and innovative. And Jenny really is a colleague at the heart of that vision. Her work's really at the core of our mission there. She's a wonderful community-minded colleague who really understands what needs to be done to support the next generation of colleagues coming through. But the thing I want to really focus on is that Jenny's really a bridge person between worlds, a quality I rate very highly. She resists the urge to silo, which is so omnipresent. And just a few examples of that would be her work around government and academia, so just the work as the co-director of the Children and Families Policy Research Unit, which works closely with the Department of Health and Social Care, so constantly bridging that gap between how we communicate between academia and government. Jenny is a bridge person across disciplines. She's a public health researcher who is often to be found in a seminar at TCRU, which has been given by an anthropologist on that particular day, or maybe a social psychologist on another day, and then easily skipping into an epidemiology workshop the next day. These are rare qualities to be able to work so actively across disciplines. She works across faculties. There are 11 of them at UCL, but in particular, Jenny's post is held across the IOE and population health sciences, thus across the Social Research Institute and ICH. And I think that bridging skill is really the quality that makes your talk possible today. Big data meets story. So without further ado, I'm going to, please join me in welcoming Jenny back to deliver her inaugural lecture to us.
Thank you, Toby. Thank you, Alison. If only it was as easy as bringing everyone coffee. So thank you all for coming. It's so nice and special to see all my favourite people, most of my favourite people, here together in this room. So this is my chance to talk about my research and my research journey. My work's about child and family health, so that's health really broadly defined. Not just an absence of sickness, but also a childhood where children are safe and have warm and responsive caregiving environments, can grow, play, develop. But we know from our own lives and also from research that that's really difficult. when the parents and carers that children rely on have their own problems which get in the way. And lots of our children in England are living with adversity, maybe fear, instability, violence. They might not be getting the emotional care or medical attention they need. They might be hungry. They might be looking after a sibling or parent. And this is not a small group of children. It's actually a pretty grim story out there that our children are living in. We've got 30% of children living in poverty, 10% in non-decent homes. Estimates of 74% of toddlers living with at least one parent with a chronic health condition, 27% with a parent with a mental health condition, and then some families have addiction in the mix. And we know that about 6% of parents will have a high-risk drinking problem known to services. Some of those children's experiences will meet thresholds for abuse and neglect, but many won't. Even those that do might not have their experiences labelled in that way. My work is about the role that health and social care professionals can play for those children living in adversity and families. But first, back to my own early years, which were happy and protected. Thank you, Mum. This is Halifax in West Yorkshire, where I was born and grew up until I was 1. And then we moved to Oxfordshire, where I lived with my mum, dad, and my brother. At school, I wanted to be a vet, an equine vet. But my grades were much better in the humanities, and that's the way I was encouraged. So I started my academic career doing an English literature degree. There we go. And then I did another one, because I didn't know what to do. If in doubt, double down. I lived in Toulouse between the two. This might seem like an unlikely beginning for where I am now, and it was a massive methods leap, huge. But in terms of topic, fairly consistent. So even then, in my early degrees, I was really interested in how health and medicine was represented in fiction and art, especially for children and families. After I finished at King's, I wanted to take my interest into a more applied field. And I got work experience here at the Institute of Child Health, which turned into a job, and then another job in UCL. 2005 was a really important, pivotal year for me. It was the year I started working on research about how healthcare professionals respond to abuse and neglect and adversity in children. And that's really orientated my whole career. It was also the year I met Ruth Gilbert, who was leading that project, and the beginning of a 20-year working partnership. That's Ruth with my middle son just after he was born. 2005 was also the year I met Roland. Another 20-year relationship that's still going strong, or someone else that's been putting up with me for 2 decades. After that, I took up a position in a different bit of UCL, the Social Science Research Unit, where these colleagues showed me the power of systematic reviewing and the place of qualitative work in public health research. And really importantly, what you get when you bring the big data and the stories together. Those 2 jobs gave me the experience I needed to get funding to do a master's, to get some methods training, and then a PhD in population health science. This was the question I asked in my PhD. What does a concern about child abuse and neglect look like for a GP, and how do they respond? What I was interested in was concerns that GPs had, which they may refer to children's social care, but they may not. And if they weren't, what else were they doing? My PhD was, from the beginning, interdisciplinary, so funded as an interdisciplinary studentship from the Medical Research Council and the Economic and Social Research Council, bringing together approaches and methods in medicine and social research. And my supervisory team reflected that interdisciplinarity. And I was very lucky with my supervisory team, but particular thank you to Marion, who really welcomed me into the social work world. I also had other colleagues at UCL and beyond who helped me, particularly with primary care data and statistical methods, which I did need, and I couldn't have done it without them. In my PhD, I used big data for the first time. So this is administrative health records, which is coded information that any doctor or nurse enters into the computer when you see them, when an adult sees them or when a child sees them. That contains information on the patient, sex and age, on the type of contact, and also on diagnoses, referrals, prescriptions. This is really good, this data. It's big, it's big. It contains millions of records, so that means it's really good for counting things and looking at differences between groups over time or between local areas, or for groups that we don't usually reach with research, like children facing adversity. But often this kind of data triggers questions. Why? Why is it going up? Why is it going down? Why is this different? And that's where the stories come in. Stories that give us the human detail, the nuance, and the explanations of what might be happening behind the big data. In my PhD, I asked doctors and nurses about what triggered a concern for them, why, and then what they did. Doing this kind of work as a single researcher, both kinds of work as a single researcher, was relatively unusual at this time, partly because each could be its own PhD. But I had a role model, Shima, who was blazing a trail ahead of me with this kind of work and was a driving force in this paper that we wrote together. So in the big data from GPs, I found really low but rising rates of coded concerns. Which begged the question, why? Why is it so low? What's going on there? And what do these groups of children look like that have been coded? It's important to remember this tells us not so much about what's going on with children, but more about what doctors are identifying and recording. In my stories work with GPs and nurses, I tried to understand why they were using those codes and when. And the main message from that was that they rarely code their concerns, because that code is permanent, it's stigmatizing, and it might, if it's seen by the patient, disrupt the clinical relationship. And it didn't reflect the uncertainty with which the doctors and nurses were working. And GPs said, this is a problem, we know this is a problem, because it makes children unfindable on our systems. We can't call them up and say, who are all the children we're worried about? Do they have the healthcare they need? Do we need to do anything? From the stories that I collected, it seemed like we might not be looking in quite the right place for coded concerns. I heard from doctors and nurses again and again that when they worried, it was because they'd seen an adult patient who happened to be a parent, who might have come in with physical or mental health problems, addictions, or possibly violence. So those concerns would have been coded in the parent's record, but not the child. Others have taken that work forward, looking at how those coded concerns cluster in parents and children, and have found really, really high proportions of families with relevant codes. Using the big data and the stories, I worked with the Royal College of GPs to think about how we might improve coding for clinical practice and also research. We settled on this one code, child or family is cause for concern, which could be used in the parent and child record at the same time, even if there's uncertainty and even if they're not referred to children's social care at that time. This was an approach that was included in the Royal College of GP's Safeguarding Toolkit, and I looked it up yesterday, still there. The interviews with GPs also told us a lot about what those concerns look like. What really worried the GPs was these children and families where there was something going on, a problem, but they were bumping along underneath the threshold for intervention from children's social care. These families tended to prompt concerns about physical neglect and physical and emotional neglect. This quote that I'm going to show you is about one of those children from a GP. So he's talking about a 4-year-old child that lives in a family where there's so many layers of adversity that that family is not putting that child's needs first. This child has a squint that they need medical attention for. He says, the GP says, just every one of the children has a problem, which of its own in a family would be a problem, and yet they seem to have them all under one roof. Medical problems, medical and behavioural problems, that kind of thing. Mental health problems. The older sister is 16. She's now got her own baby. And they've had to have a room in the house. So I think he shares with 2 siblings and the brothers are in another room. I mean, all the kids have got some problem of some sort or another. And the parents have their own problems. The mother's had a stroke. The father's had a heart attack. Unless something is done soon about the squint, he's going to lose his eye. We're not talking about surgery or anything. We're just talking about patches and covering and making sure he uses the eye. So you can see here where the social and the medical get very, very tangled up. And the GPs told me, we don't know where to begin helping these families. But they did try. They told me they tried. And what they did is they obviously referred to social care, but also they called those families back proactively and made sure they kept coming to address their medical needs whilst also keeping an eye on the social. They worked with mothers, always mothers, to try and get them to be able to see and put first their children's health needs, and they advocated for housing and speedier specialist care. All of those responses relied on the relationship with parents. And GPs went out of their way to build that, they told me. They saw that as necessary but risky. Risky because working with the parent potentially means that you overlook the needs of the child. So this was quite controversial, actually, invisible work that was quite controversial. And even some of the GPs said, you know, this is social work. I shouldn't be doing this. Should I be doing this? I don't know. But we did manage to get these kind of approaches backed by the charity, the NSPCC, and the Royal College of GPs. And I wrote a report with those 2 charities articulating why it was a good thing to take these kind of approaches in general practice. The NICE guidance from 2017 really emphasised the relational approach, and our work was cited in that. During my PhD, there were bad times as well as good, particularly on our journey to parenthood. And at one point, I thought I might not finish. I had to take quite a lot of time off. But I did finish in 2014, and that's me there with my son, who was born the year before, my first son. I also made lots of friends during my PhD, lifelong friends, people I'm still friends with, and many of whom still work at UCL, actually. So my PhD was the first example of how descriptions of business as usual service could really articulate a way forward for policy to take up. Thinking about what good practice might look like and where the risks and pitfalls were. I think of this work, I still think of this type of work, as holding up a mirror to practice. I have reflected over time that that's quite a bold thing to do as someone I'm not a doctor, I'm not a nurse, I'm not a social worker, I'm no kind of practitioner. So to be explaining to people who work in the service what they're doing is quite a bold move. It requires credibility. It requires sending out the signs and signals that you understand what they're trying to do and in what contexts. And then how do you get that? By kind of stealth anthropology, going to conferences, lectures, reading between the lines in meetings and documents, and also people helping you. This is my set of 3 GPs who are absolutely instrumental in me building credibility during my PhD. And I've got a particular thank you to Janice, who sat with me for hours and hours explaining what it's like to be a GP. So, things were going really well during my PhD, finished on a big high. But then my career trajectory did slow down a bit. I applied for a fellowship from the NIHR, didn't get it. I applied for one from a different funder, didn't get that either. In fact, I was wondering whether academia was for me. And I was applying for other jobs at the same time. I was thinking about going even more applied, so into public health teams in local authorities. And I got a job. I got offered a job by Oxfordshire County Council Public Health Team. And I thought long and hard about taking that. And I didn't. I stayed in academia. As my work life was slowing down a bit, my home life was speeding up. That's a picture of my dad. That's a picture of my dad who died with my second son. Moving on. After my second set of maternity leave, I got a job as a lecturer in child and family policy at Coram Research Unit, where I'm still based. And that is part of the UCL Social Research Institute. I've really benefited there from being surrounded by social researchers. So exactly as Alison was saying, the anthropologists, the social psychologists, and I'm learning from you all the time. I've also been incredibly lucky to have a very supportive leadership team who've really helped me balance the demands of teaching with my research. And a particular thank you to Margaret, who also sat with me for hours discussing my career and really championed my work. Thank you, Margaret. After I started in the Coram Research Institute, which is still my main home, I took up an award from the Academy of Medical Sciences. I used this award to really get some skills and expertise in the children's social care data. So from my PhD, I'd seen already how much you needed to understand about the service and the way the data was produced in order to meaningfully analyse the big data. And I didn't have that for children's social care. So that's why I wanted this award, to get those skills. I looked around for people to help me, and I found Lisa Holmes and Nikki Luke, who've been incredibly generous with their time and expertise, still now. Thank you, Lisa, for coming. Together, we set up this knowledge exchange network, the Children's Social Care Data User Group, which is, it's got 200 members at the moment. You can still join. And this is about sharing knowledge and expertise across the sector, the practice sector, academics and charity, so that new entrants to the field can analyse the data meaningfully. This was about the time my third son was born. So that's the completion of our busy household. When my children were really small, I worked part-time for quite a long time, actually 6 years, 3 days a week, and then 4 days. And this is one of my proudest moments. I was featured in the Academy of Medical Sciences MedSci Life campaign as an illustration of a part-time scientist. This is actually, I recommend you go and have a look at this. It's a really nice campaign, which is about work-life balance for medical sciences. Some of you who've got good eyesight will see that I'm not the only one featured. We've got Catherine Law and Lola Schliebo here with much bigger features, so you should go and have a look at what's been said about them. This next study is one that illustrates how we can use research, how we can use descriptions of practice to help implement policy. Multi-agency safeguarding hubs, or MASH, are teams of professionals, social workers, health, police, and sometimes education, domestic violence, early help. When a child is referred into children's social care, they will gather information about that child and family and share it with each other. The idea is that having the fullest picture, helps social workers assess risk accurately to the child and make decisions about what to do next. So this study is just finished, not published. It's coming in June. Watch this space. We knew when we started this study that MASH were widespread. They were all over the place in England. 93% of local authorities said yes when we did a survey, or Rowe did a survey. Yes, we've got a MASH in some form. But we also knew from the same survey and from the literature that they were highly variable. They were so different from each other that you might actually wonder whether they were the same thing at all. So, that was our task in this study, not only to mirror and reflect practice, but to make sense of it and draw theory. So, to make meaning about the variation and complexity on the ground. So, there's no big data here because there's no big data on MASH. So, this is all stories. We found 2 distinct types of MASH. So not complete chaos, 2 distinct types with different strategic functions. The risk assessment MASH, which was designed primarily to accurately assess risk to children, dealing with really high volumes of complex cases. Second type of MASH did that, set up to do that, but also to do needs assessment and service planning for children at the lower end of the risk spectrum. These functions of MASH were in the literature, they're not new. What is new is the fact that we found not all MASH are set up to do all functions or all functions equally. We also found that there's a lot of background activity to make a MASH work well. The building of the professional relationships, the building of the shared culture, the understanding of what pieces of analysis, what pieces of information are needed for the analysis and how to present them to your colleagues takes time. All that stuff you can think of as the wiring behind MASH. It might be invisible from the outside, but without it, it just won't work. This is important because this is important information for the Department for Education, because they are currently leading children's social care reform in England. We have the Children Wellbeing in School Bill currently going through Parliament and associated guidance. So one thing that this legislation proposes, among others, there's lots, is changes to multi-agency working. We, through our funder, Foundations, we have had 4 workshops with the Department for Education discussing the implications of our findings for their new multi-agency policy and legislation. In my view, the big hitter findings are that the multi-agency family help that Department for Education is proposing in this document is very similar, looks very like those needs assessment and service planning MASH. So that's good news, because it means that the policy and the innovation on the ground in some areas are heading in the right direction together. But we also had warnings that for some local areas, these kind of MASH, which are resource intensive, would seem very, very far away from what was feasible or realistic. And that if those local areas tried to implement this model without the proper wiring, so that's the resource, the culture, all that background stuff, then it isn't going to work in the same way as it should and not have a very good chance of making things better for children and families. This is an example of a study where describing practice can help policymakers see where you're pushing at an open door in terms of policy and where the big potholes in the road may be, which you need to cover up. Much of my time these days is spent on the NIHR Children and Families Policy Research Unit, which I co-direct with Ruth Gilbert. This is a fairly large consortium of academics and lay contributors across 11 institutions. This programme of work is funded with the specific purpose of providing evidence to the Department of Health and Social Care as and when they need it and in the form they need it and can use it. There's 20 of these policy research units across the country. So there's one in mental health, there's Mental health, healthy weight, dementia, and Ruth and I lead the Children and Families one. This slide shows just some of the work that our policy research unit, so not me, all the colleagues, have published over the last year. Much of that uses the big data we've been thinking about, but not just from health, linked with education and children's social care and sometimes family justice, to really think about how services are coordinated or not for children and their parents. We also collect and analyse stories to make sense of the big data. And we do try, even when we're doing big data, and even when we're thinking at a high national policy level, we do try to keep children, young people and parents' voices centred. And I have a thank you to Lauren and Claire for always keeping us straight on that. But I'm not going to talk about any of this academic work today. I'm going to talk about how we work with policymakers. One of our main activities is talking to policy colleagues, and we do that in all kinds of different ways. Early conversations about topics or methods, seminars just for the Department of Health and Social Care, question and answer sessions on our projects, and we've also done secondments both ways. So this is really, all that activity is set up to transfer knowledge back and forth across the science policy interface. One of the things I think academics can do, rather than, for example, in-house analysts in the government, is we can help policy colleagues think about how to conceptualise problems and solutions, so ways of looking at things as well as data and evidence. And I want to give you a bit of an example of a project where I think we did some of that. So this is a responsive project within our policy research unit, which means it's commissioned directly by the Department of Health and Social Care for a pressing policy question. The question was, should the DHSC keep the currently mandated tool to measure child development aged 2.5, or is there something better they can use? So they wanted us to look at other tools. Are there other tools? Are they feasible? Are they equally accurate? And we said, yes, we can do that. But perhaps we should also think a bit more about the system in which that tool is delivered. Think a bit more about, there's a health and developmental review for every child in England in which that tool sits. How is the tool functioning in that wider review? So we spoke to parents and professionals and policy colleagues about what they wanted, not only from the tool, but also from the wider part of the healthcare system. And we found a possible alternative tool called the Caregiver Reported Early Development Instruments, or CREDI. Feasible, probably about as accurate as the one we've already got, and free to use, unlike the mandated one at the moment. But we also found that what everyone wanted, loud and clear, professionals and parents, was a holistic needs assessment across the family system. So what that meant was, as this parent put it, a warm conversation about what's going on, not only for the child, but also the parents, with reassurance, guidance, and possibly a bit more help if they need it. What came across from this project was that any tool, whichever tool they use, it needs to support the primary functions and mechanisms by which the service works in which it sits. So it seems like quite a simple point. Let's not introduce tools which undermine the way the service works to help families. But I think as policy colleagues, when you're focused on one particular task, which is, do we need to switch the tool? Sometimes you need a bit of partnership working to look a bit more broadly. So the Department of Health and Social Care are taking this work forward. So they're in the middle of commissioning a study to look at how CREDI can be implemented in England. So that's promising. But this is also an example, I think, of how we worked throughout the project with policymakers. So right from the beginning, we were having meetings with them. We had 9 meetings over 12 months with policy teams, sometimes including MPs. So this was a very politically charged topic politically charged topic at the time, because it was when Andrea Leadsom MP was really campaigning very strongly for intervention for babies and young children. In those meetings, what I observed was that having an empirical project, a live empirical project, could create a safe analytical space where you could really think together, academics and policy colleagues, about how the service was currently working and the possibilities and risks for changing bits of it, away from the political heat that surrounded that. Working in this way, responsively, with policy is a bit of a tightrope situation. So partnership, yes. Independence, also yes. We're no good if we're not independent. It's the same with complexity. The example I've just showed you is about bringing complexity into the question. But we don't want too much complexity, because if we start talking about the whole system, then that becomes overwhelming and looks like we're being obstructive to innovation and change. It's a constant step forward, step back, I think. This responsive work, and I lead the responsive project, the responsive facility, it's tricky, and it was a steep learning curve when I started. So I'm really grateful, Catherine, for your guidance and advice as former director of the Policy Research Unit. Thank you. So while I was doing all this, home life continued in its wonderful chaos. This, if you can't read it, says, it's a slip. I found it when I was looking through the photos in my phone. It says, Jack, that's our youngest son, had an accident at school. You get a little slip. Details, nosebleed, put stick up his nose, applied ice pack, signature. So standard operating procedure in our household. There's always something going on. So this brings us to the last body of work that we're looking at, health visiting. As many others have argued, including people here today, if you really want to make a difference to child and family health, the early years before school is a good place to start. Health and development in those early years can really set the trajectory into childhood, into adolescence, and then actually for the rest of your life. So we in England do have a public health system for the under fives. It's called health visiting. As you can see, so most of this work I lead with Katie Harron, so it's a joint venture. As you can see, we've got a big team now, and it's across lots of studies and working across lots of disciplines. The basic structure of this service is that before you go to school, every single child and family in England should have 5 health and developmental reviews, shown here in the coloured boxes, at specific times of their life, delivered by a member of the health visiting team. For those families that need a little bit more or a lot more, one thing they can have is additional contacts from the health visiting service. And those mandated contacts, so the ones that everyone gets in colour, are used as key performance indicators. So that's what's measured and looked at routinely by the government. So this each year, the Department of Health and Social Care spends 900 million on this. Seems like a lot of money, but actually that's a real term fall of 37% since 2015. At the same time, we've had a workforce decline. The big data I'm going to show you in a minute from health visiting covers these periods, so you can see when there's already these operational challenges in place. My interest in health visiting was partly because this is exactly the type of public health service we need if we want to help children and families, but also because I had a conversation with a policy colleague from the Department of Health and Social Care in about 2018 or 19. He asked me lots of questions that I didn't know the answer to, like, how many children actually see a health visitor before they go to school? When? What time in their life? With what frequency? And how worried should we be about the ones that aren't seeing a member of the health visiting team? So those of you who are not familiar with this kind of work, you might think it's quite crazy that the government is spending £900 million on a service and can't answer these type of questions. But it's not the only place. This is happening all over. There is such complexity and variability on the ground that the government can't make sense of what's going on. So Kent will know what Kent's doing, Oxfordshire knows what Oxfordshire are doing, but we don't have that big picture description. We did some scoping work with policy colleagues at the beginning of all this work, and I love this quote because it's exactly right. Policy colleagues said, the variation between different local authorities, so areas, is so stark, it's really hard for us to understand what the offer is. So they don't know what the infrastructure is. They don't know what health visiting is doing. How can they innovate, change, improve a service that they can't see? So I thought, you know what's missing here? Some nice sense-making descriptions of practice, and I was happy to oblige. One thing we looked at was these additional contacts. So we knew a little bit about the mandated ones, the ones every child should get, but those additional ones, we didn't even know if anyone was getting them. Budgets are falling, health visitors, not enough of them. Are they even able to give those additional contacts? And what we found in the big data was that, yes, they are giving them. In fact, in most local authorities that we were able to look at, 57, the local areas were providing more additional than mandated contacts. So the burden of their activity was not the stuff the government's measuring, the key performance indicators, but the additional contacts. But, you might ask, are these just short telephone contacts, kind of check-ins, maybe arranging appointments? No. 83% of those additional contacts were face-to-face, so in person, in a clinic or at home. And on average, 30 minutes duration. So something's going on there, some kind of work. It's not just administrative. This data here takes a very area-level approach, thinking about what's happening in local authorities. We also looked across a child's life. This is my favourite graph. Catherine, where's Catherine? Thank you, Catherine, for my favourite graph. Where you can see first, so we could only look in the first year. The data's a bit dodgy, okay? The health visiting data is very incomplete. So that's when we try and look longitudinally, the sample gets smaller and smaller and smaller, and we've got 10 local authorities here. You can see for these 52,000 children in 10 local authorities, 79% had three or more, had all three of their mandated contacts. It's pretty good coverage. When we look at the additional contacts, again, you can see lots of activity. And 25% of those infants had three or more additional contacts in the first year of life, adding up to an average of 4.5 hours with the health visiting team. That is a lot of contact time, a lot of contact and a lot of contact time for a very substantial minority of children. If you add those together, the mandated and the additional, you can see right at the end that 8% of children had 10 or more contacts with a health visiting team in their first year of life. This was not what we were expecting at all. There's no health visitors, there's no budget, very high need, but you look, they're seeing them. Don't know what they're doing in the contacts, but the infrastructure, the opportunity to intervene looks like it might be there in this pre-COVID data. To make sure we hadn't got it all wrong before we started disseminating this, I did a little tour of health visiting, not in a camper van, just online, but talking to the service leads in local authorities, showing them the data we held for them and saying, is this right? Is this what you do? And that was very reassuring. So, the big data only takes us so far. We can see a bit that those additional contacts are socially patterned, which is good. We want them to be going to families who have indicators of higher need. But it's really the stories we turn to get a sense of who those families are that are getting all those contacts and what's happening in them. Our interviews with staff and parents indicate that although health visitors are identifying need across the whole spectrum of family health, the pull is to delivering those additional contacts, supporting families at the sharp end, families in crisis. We had some really, really powerful accounts from mothers and health visitors about the work that they were doing at the sharp end, supporting families in crisis. I'm going to show you a quote from a mother who was given intensive support after her child was born from the hospital crisis team, so that signals how bad it was, from the perinatal mental health team and from the health visitor. At one point, she had people coming into her home from those teams every day, multiple people every day. So this family is one that would fall into that very intensive pattern of service contact. She says, talking about health visiting, "It's had an impact on me and my life, but a much bigger impact, I think, on my children. And now I am a better mum than I would, much better mum than I would have been. I probably would have thought it was okay to smack them or throw things at them or drag them or threaten them. I would have thought it was okay to leave them to go out the house, because all these things is what I experienced, and I didn't understand that it wasn't okay and it wasn't normal." So not only did this, by the mum's own account, not only did this health visitor intervene in the mental health crisis, but has done some longer term work there about warm and responsive caregiving. She goes on to say, "Without her, things could have got worse. She caught things before they got to the point where I might have lost my baby to children's social care, or I might not be here. So yeah." So that is, I think that's a really powerful testament to what the health visiting service can do when it works well. It's important, difficult, skillful relational holding work. But it does trigger some policy questions, I think, which is, given the limited resources, and there are limited resources, there's lots of families that don't have the services they need, is that what we want health visiting to do? That to respond to that very sharp end of the spectrum? And if we do, then who is going to be looking after all the people who are less in crisis and dealing with their family health needs? Because they can't do everything. It also begs the question, should we maybe measure, capture this work, which is not apparent at all because we don't measure additional contacts, in order to value it and understand it? I just wanted to reflect actually on something that Janice said to me outside about my health visiting work, about our health visiting work. She said, the problem is, if nobody knows what a service is doing or what it is, people think they're doing nothing and they don't value it. So for me, that's the real power of describing and making sense of services. So to really show the outside world what's going on, so that we can think carefully about what to change, what to keep. So, I'm coming to the end now. Was I right to stay in academia? Should I have gone off and taken my public health job? Well, with a bit of hindsight, no, it was good I stayed. But really I stayed then because I couldn't quite leave the things that I loved, which are the intellectual freedom, the autonomy to chase ideas and new ways of thinking, and above all, the people I work with who are really thoughtful, knowledgeable, considered people who have a shared vision for making things better for children and families. And that's not just academics, that's policymakers and local authority colleagues as well. In terms of where next, I just plan on doing more of the same, basically. Luckily for me, there's lots of bits of the system, the healthcare service, the children's social care service, which are invisible, where we don't know what's going on. So plenty of work to keep me going. And as Alison said, I now have a cross-faculty post, which I really hope is going to help bring on and train the next generation of interdisciplinary public health researchers to look at these really complicated and variable services. I absolutely think the way forward is to look at how we're delivering public services across health, education, social care and beyond with the big data. But I'm also aware that the parents we work with keep saying to us, so not our participants, our lay contributors, they keep saying, but where we turn when we're in trouble are charities. It's not the doctor or the hospital or social worker, it's charities. And we can't measure that in the data we use. But my vision is that we need to include it. And we are moving that way in the Policy Research Unit. Finally, I'm really looking forward to working a bit more with local authorities. For example, Camden, where there's some really, really exciting things going on, looking at how services can reduce child health inequality, but also thinking about those social determinants. Poverty, housing. And I hope we've got Abby Knight from Camden here. I don't know where she is. Yeah, thank you, Abby, who's been inspiring me with their vision for change. I recommend you go and have a look at the website. So before I finish, just a few thank yous. To the participants, so the mums and sometimes young people who talk to us, and they tell us their difficult stories. They share their difficult stories. To the professionals who tell us what they're doing and why, in all of its messiness, usually they don't know what they're doing or whether it's the right thing to do in these cases. To my students, so the undergraduates, the masters, and also particularly my PhD students, it's such an honour to learn with you. To Kate Evan-Jones, who is our lay contributor, so our parent representative in our Policy Research Unit. I have lots of one-to-one conversations with Kate, and it is one of the favourite bits of my job, her insight, her thoughtfulness, and her reflections on what it's like to live with a child with complex needs and navigate our system of services. Finally, my wonderful colleagues, Charlotte, Katie and Pia, who are not only leaders in their field, but also wonderful friends who I don't know how they get any work done because they give me advice about every 5 minutes, from statistics and methods to, what I should do in my lounge. Last but not least, my wonderful school friends who've come from all over the country to support me. They were here for my dad's funeral, and they're here now. Thank you. Roland and my 3 chaos makers. And last but definitely not least, my lovely mum. Thank you for listening.
So, thank you very much, Jenny. My name's Ruth Gilbert. You've heard a bit about me today. So just a few minutes before we go for refreshments, Jenny asked, was she right to stay in academia? Yes, absolutely. And UCL was so lucky to keep you, or to get you back, Jenny, when she was very polite about 20 years ago when Jenny came to do work experience with me. Now, that was 20 years ago, but she worked for free for 6 weeks, and I very quickly realised I needed to pay her and needed to get her a proper job. And I don't know if I've ever told you this, but the referee for that first job described Jenny as self-driven and turbocharged. Kind of a phrase you wouldn't want to use now in sort of Tesla era, would you? But she was clearly a star. And and then you put your energy and your tenacity that we've seen today into a fantastically impressive career here, and we've all learned from you. Now, the line I was going to then talk about was the ardent bridge building. And Alison, you took my line, but I just want to emphasise a few points from that. One is Jenny's just shown what an art it is, working closely, building bridges with government while maintaining independence and keeping that sort of long, that conversation going and ideas development, which is the most exciting thing, I think, for our policy research unit is seeing things change, seeing thinking change, and ultimately seeing policy change. Really hard to measure in these impact assessments. We can't get at it. It's very hard. And then secondly, with the data side, I mean, the future is big administrative data, but you've seen today so eloquently how difficult it is, how you really need to bottom out what is the service and what are the experiences that generate that data in order to bring meaning to these analyses. It's not just AI and big fancy causal inference methods. It's really understanding where the data comes. And then the third point I want to make is the bridge building between our institutes within UCL. From the Institute of Education, Institute of Child Health, and those two realms of research, which really they're long overdue for being better connected and more integrated to drive more integrated services in the future. So Jen is the start of that, and may we have many more inaugurals from the IOE and the SRI, whatever acronym it is, here. So the last thing I want to end with is on your website, Jenny, there's or on the IOE website, there's an interview with you, and you're asked about some of the important things you learned. And you said, you're quoted as saying, one of the important things you learned was that a teacher never stops learning, especially from their students. Well, I've never stopped learning from you. You were once my PhD student. And I think we've all today learned a lot from Jenny in a way that perhaps only you could have taught us, actually. It's been really insightful. So can I ask all of you to thank Jenny for her terrific inaugural lecture today. Thank you.